I am very happy to be hosting Dr. Mtebe Majigo to discuss his recent PLOS ONE Lab Protocol paper entitled Protocol for Surveillance of Antimicrobial-Resistant Bacteria Causing Community-Acquired Urinary Tract Infections in Low-Income Countries, and the associated detailed protocol in protocols.io. Majigo is a clinical microbiologist and immunologist who works at Muhimbili University of Health and Allied Sciences in Tanzania as a senior lecturer in the Department of Microbiology and Immunology. He has extensive experience in health-related activities, including research, disease surveillance, capacity building, consultancy, clinical program implementation, and medical laboratory management. He has authored and co-authored over 70 articles published in major national and international peer-reviewed journals. In addition, he has supervised over 50 postgraduate and undergraduate students. He is the current chairperson for the National Technical Working Group for Antimicrobial Surveillance and Research. Majigo, thank you so much for being with us.
Oh, thank you. Thank you.
So to kick off, can you briefly explain what the protocol is about, how to use it, and why it is relevant?
Yes, as you said, you pronounced very well the title. This is a protocol for surveillance of antimicrobial-resistant bacteria causing community-acquired urinary tract infection in low-income countries. So we are using the word low-income countries because this protocol was developed in Tanzania, and Tanzania is one of the low-income countries. And we think the application of this protocol can be even in the other countries like Tanzania. So the protocol is about designing a methodology for surveillance of antimicrobial resistance in the community. We clearly understand the infection, the pathogens which cause infections in hospital environment, and the pathogen which cause infection in the community environment actually differ in terms of the level of antimicrobial resistance. So that's why for us, we are focusing on designing this protocol of conducting a surveillance in the community. So the last common conditions which are community-acquired infection. One of it is the urinary tract infection. So that's why we selected urinary tract infection to represent some infections which are acquired in the community. So what we need to do is, because currently the issue of antimicrobial resistance is a global issue. So surveillance is in one of the methods to monitor the antimicrobial resistance. And in low-income countries, we are lacking actually the resources for proper conducting this surveillance. So some of you need to have a well-equipped laboratory in order to conduct this surveillance. So in the community and in the low-income countries, laboratory infrastructures are not well established. So that's why we are designing this so that you can get information from the community, so that you can't just collect information in the hospital while the pathogens, there are disparity between the hospital and the community. Our protocol needs to collect information also from the community in order to have a national representative antimicrobial resistance data, which are not concentrating in one part. So the relevance, and I think this is relevant because because it enables to collect data in a places with low resources. And that I think, this data are required. So this design help to conduct the surveillance like in other areas with well-equipped laboratory infrastructure. But we may manage to get these data from areas whereby the resources are not adequate. I think in brief, that's what I can explain about this protocol.
And to further understand the significance of your method, your protocol, can you elaborate on what sets it apart from other surveillance protocols that already existed when you started your project?
Okay, so other protocol, the existing protocol, it's just a protocol for surveillance of antimicrobial resistance. And the existing protocol needs a well-established laboratory. So it was not possible to utilize the existing protocol to conduct surveillance in the community. So that's why we designed this, because we think it will be more significant to have data from the community. If you use the existing protocols on antimicrobial resistant surveillance, actually you will not go get data from the community, because what is needed, it is a passive surveillance. Even existing surveillance is a passive surveillance. But there is an active surveillance. So we wanted to get data from the patients who are attending the health facilities. So what you need to use is a passive surveillance. So the current protocol needs it for a passive surveillance. You need a patient coming, you get a specimen, you test in the laboratory, and then you get the data. You accumulate that data, you analyze, and you can know the magnitude of antimicrobial resistance. But so if you use that existing one, you will not get an opportunity to get data from the community. So for us, we have designed in such a way that you go to the community, you correct you see patients who are attending the health facility in the community, you correct data, you correct specimen, and you test, and you can get exactly the data from the community, but which cannot be achieved with existing protocol.
So what would you say is the most crucial element or most crucial step to get high quality data in these low income settings?
Okay, so we have designed a protocol which it has the preparation before beginning of the surveillance. I think this is the most crucial part, because you need to prepare before you start conducting the surveillance itself. You need to know the areas which you want to go and correct. And you know there is in that areas, it should be representative of the community you want to study. There are a lot of bacteria causing an infection. So you have to select, you have to decide which bacteria will you be isolating. And you have to determine which antimicrobial agents will you be testing against these bacteria. So that's why for us, we selected the community-acquired urinary tract infection, because this is the most common in our community. And then we selected antimicrobial agents which are targeting the bacteria which are isolated from the community. So that's very, very important to start with. The second part, which is very important, is a sampling plan. You have to plan how many samples will you be collecting for a day. So you have to recruit the health facilities, the number of health facilities to give you the samples, which you have, the lab you will be using has capacity to test those samples, because that's a very good plan. You make sure that you know the number of samples per day, and then the sampling frame, how many, when will you go to collect the samples, and for how long. So that's very important. And then the other thing is the preparation for materials and the reagents, because this is a surveillance which is set for a particular time, and then you use the lab which is not used to take those samples. So you have to clearly prepare so that you don't reach a point you run out of materials and reagent. So it's very, very important to clearly understand what material do you need, and you prepare them, because when you start collecting, you don't need to stop. Since you'll be going to the community, sometimes the community people might think you are doing something which is not maybe advantageous to them, which are relevant to them. So instead of telling everyone and then everything, you have to engage the stakeholders in the community on setting and planning, which includes stakeholders in the public, private, non-profit organizations, and then the community leaders. You discuss with them, you clearly understand, they understand what is need to do, because for them, they will be sending a message to community members. So it will be easy. You will not get any obstacles when you are implementing. I think that's a very important things to prepare. So the initial preparation is the critical part for this for conducting this protocol.
And as you were developing the protocol, the workflow, and the methodology, was there anything that, let's say, you tried or you planned and then realized that it wouldn't work, and then it didn't make it to the final version of the protocol?
Yes, so when we started, when we designed, we piloted it, and actually through piloting, we actually identified some difficult things. Sometimes you might think it will be straightforward, but when we piloted, we found there are things which we wanted to modify. For example, the assumption was that we said go to the facilities with at least a certain kilometer, not more than 50 kilometers from the testing lab to the facility, aiming that immediately after collecting a sample, you have transport the samples to the testing facility. And then, so we realized sometimes it was difficult to meet the required time before processing the sample. So we had to change. So for now, what we are saying is that because it is urine, we have to preserve urine so that it will not overgrow. So initially, we didn't consider preservation. But now the urine need to be preserved by boric acid. So correction, you preserve it, so at least it has time. When even if you delay, it will still be okay for you testing. So those are the things we modified. There are other minor things which we modified. For example, you have a testing lab. The people you think they will do it, but you have to enter into contracts for that. They understand. And then giving them incentives for them to test. But we think going forward, for those who want to implement, these are the things they need to actually clearly understand and agree, instead of assuming that this will just test it. So in short, those are the critical thing is the timing, and then the preservation of urine sample.
Thank you so much, Majigo. And changing gears a little bit, I would like to ask you about your motivations, your team's motivations to put together the protocol in the platform of protocols.io, but also to send it to peer review to PLOS ONE.
Okay, so we started a national antimicrobial-resistant surveillance in Tanzania, the country. We were using the existing protocol, and then we collected data from the hospitals with adequate laboratory infrastructure. So what we found, we initially got high level of antimicrobial resistance. So actually, so it was actually it was actually very difficult to accept. And then we come to realize that maybe this is due to the fact that most of the patients which we are recruiting in the current existing protocol is patients who are getting infection in hospital. So they have high resistance. These pathogens have high resistance. So our motivation, because as you introduced me, I'm the chair of the technical working group, the National Technical Working Group for antimicrobial resistance surveillance. Seeing the data, analyzing it, we were motivated that we need to do something. We have to check what we are getting. It is a national representative, and then actually the answer was no. So because we are not recruiting from the community, we want to see if the situation in the hospital is the same in the community. So that's what motivated us. So when we piloted it, we found the data. Actually, there are some differences. There is still low antimicrobial resistance in the community compared to the hospital. So the decision to submit for review and publish it, as we introduced, we said this is very important for those who want to establish a national surveillance for antimicrobial resistance, which can inform the nations. So they have to go to the community. So we decided to publish to help whoever wants to use it, so that they can use the same and get the data from the community. We decided to submit for peer review to get the views from others. What do they say about this protocol? Because you might have it, you think it's okay, but when you publish, you will get feedback from reviewers and feedback from those who are reading.
And building on that last point, how did the feedback that you received from the peer reviewers shape the final version of the protocol?
Okay, so the comments from peer reviewers didn't change much our protocol. It was in most part actually it was praising it, that this is very relevant, and some questions, some comments for clarity, well defining. They wanted to be more clear. When you say the low health facilities, what does that mean? Because for us, we were saying low health facilities. So they wanted it to be well defined so that it is clear. There are some statements which you say this will be used in a national database. So they wanted it to be very clear how this will reach to the national database. How will you compare with others? So it was much of clarity. And actually, we thought that was very relevant for clarifying, because we being scientists, we sometimes we think everything it's well known, it's clear, but when someone reads, there were a lot of some questions to change some statements for clarity. So it didn't change much the design, but it was just for clarity, so that whoever is reading clearly understand what the message you want to send.
And what was your motivation to make the peer review history public and to publish it together with the paper?
But I'm a senior lecturer. I'm a scientist. So we are teaching students, postgraduate, undergraduate. We are doing research, and we are promoted based on the academic activities. Research is part of it. So the motivation to send for peer reviews actually, apart from the fact that we wanted everyone to know, and then to be published and with a language which is not clear to everyone, it was also part of our motivation as academic staff for promotion. because when you publish, you are promoted, you gain credit for what you do, contribute to the academic forum.
Yeah. And my last question is, you are a very well-seasoned researcher with years of experience. And this is a relatively young paper. It was published 6 months ago or so. What do you think will be the impact for your career of having published this methodological paper?
So we are receiving questions and some assistance from people who are interested in doing the same. We also went to the national at a national level. We have a multi-sectoral coordinating committee, which are coordinating the antimicrobial resistance activities in the country. We are implementing the National Action Plan for Antimicrobial Resistance. So when we were reviewing the current the framework for antimicrobial resistance surveillance in country, they now considering including our protocol to enroll the patients in the community. So how will that be designed? So they will use the protocol which we have published. And I think that is very important, because now it will be used. We understand even other countries might be using it, because we are seeing the announcement for some donors who are supporting the antimicrobial resistance surveillance, encouraging conducting this surveillance in the community. So although we have not heard that what are they going to be using, we hope if they will be using they will be conducting in the community, automatically maybe they will consider our protocol, because that's what is targeting. So we don't have other clear protocols which are targeting the community. So we think ours will be used in most in some countries also, but in our country this will be used soon, because we are revising the framework now.
Thank you so much, Majigo. That was my last question. I don't know if you would like to add anything that haven't been discussed so far.
Yes, I'd like to ask you, because I don't know what you noted in our protocol, and then you decided to come to invite us for this interview. Maybe if you can share with me, and then I will share with my colleagues that the reason for being invited, maybe they were impressed for something. Maybe if you can share that.
Absolutely. Two were the main reasons. So the first one is that I am particularly interested in research that is done in low-income settings that have a social impact. And I think that your protocol exemplifies that type of research. And the second is that protocols.io was originally designed or thought considering the wet molecular lab. So protocols for pipetting and mixing and centrifuging. And you took that platform and you made a protocol for epidemiological studies. So I really appreciate the way that you adapted a tool to fit your needs, which are not quite the same as when we developed the platform. Those are the two main reasons why I wanted to talk to you.
Oh, thank you. It was challenging when we decided that we have to publish this. As you said, wherever we were checking other protocols, we found it was more molecular lab testing, everything lab testing. And so it was somehow difficult in which category should we put ours. And actually we were assisted by, I think, is it editor or reviewers? We were assisted that I think this fits in the lab part. So initially it was challenging. Where should we put? So we had to describe exactly what we'll be doing. What does that mean? What message do we want to send? So they said maybe this fits much in the lab protocol. So yes, as you said, it was initially challenging to design a protocol like that, because other example protocols was more of lab based. Thank you very much.
Yeah. No, thank you, Majigo. I don't have anything else to add.
No. I think it's okay. Maybe just to welcome you if in case you get any other things which you think we can work together. If you have maybe you are interested with anything, to do it in low income countries, you want to collaborate, I'm available for that. Me and my team. And also I take this opportunity to thank my colleague, which we published together. This is I'm talking on behalf of others, so it was a work of me and my professor Stephen Mshana, Eric Komba, Dr. Nyambura Moremi, Professor Mek Mati, and we got support from our framing fund, which was given to end pandemic. Thank you.
Thank you, Majigo.